You did it.
Okay, I got it. How about it? All right. Well, first off, everybody, I just wanted to thank you all so much from the bottom of my heart, helping me with my DNP project. This is something that I personally wanted to do for a really long time, but I'm so happy that it's presented me an ability to educate all of you even more than you already have been about endometriosis. And it's the goal of my project to keep this as something that we have in my clinical practice with Dr. Harkins and the team. So hopefully this is going to turn into something that's going to be long lasting and evolving based on your feedback and based on how this all goes. So when I started this project, put together a number of you that are here to help me figure out like, what's the most important things to patients and to you as endometriosis patients? What do you want to know? And we tried to focus on the three topics that I thought were important. What is endometriosis? This week, we're going to talk about that. Next week, we're going to talk about how to treat endometriosis. And then the last week is really, I think, one of the most important things is how do we live with endometriosis and what can we do to keep our quality of life. And that's really what my project here is all about, is how much does these types of social media education sessions, how much can that improve the quality of life of a patient with endometriosis? So that's my goal. That's what this project is all about. So I tried to make these PowerPoints not really long. I didn't want any of this to be time intensive to all of you. So I'm going to try to share my screen. Again, technology is not my friend. Can y'all see my screen?
Yes.
Okay.
Yep.
So again, this is what is endometriosis? This is the first of 3 of these sessions that we're going to do. And that's the title of my actual project, Social Media Education Sessions for Women with Endometriosis, a Quality Improvement Project. So I wanted to start with this slide because I know that it resonates probably with many of you as something that you've heard or something that you've been told or that something a provider may have talked to you or said to you about endometriosis. So I always tend to start this talk when I give it, whether it's locally or nationally, with this slide, because I really think it sums up how many of you feel and how many of you have felt living with this journey. So what is endometriosis? So endometriosis itself is a chronic inflammatory disorder that significantly alters the quality of life in many women. And it can be influenced by multiple factors. One can be genetics, another one can be environmental, and the other one could be epidemiologic. And the cost to society is really staggering. It's estimated to be $49 million due to surgery costs, but when women are out of work, unable to do what they need to do throughout their lifetime, the productivity and the cost could be double that. So that's astronomical when you think about how much this affects women and actually affects society. So there is endometriosis can affect 6 to 10% of reproductive age women, and it can be present in both pre and post-menopausal patients. The average age at diagnosis is, I think I can't see my slide there, but I think it says 27 or 28 years of age. And many women spend, up to 6 to 8 years involving many different subspecialty providers being told that their colon is normal, their bladder is normal, everything is normal, when there really is something wrong. What's interesting with endometriosis is there's a 7 to 10-fold increase in first-degree relatives. There's a very strong familial component. With the genetic burden of disease can increase the severity of the disease. So the more of our female relatives that have endo, sometimes we see more severity of disease. So what's the pathophysiology? Like what makes endo? Why is it so painful? Endo is painful, and the reason is which tissue that it normally lines the inside of your uterus, the endometrium, grows on the outside of your uterus. And endometriosis itself is diagnosed by the presence of viable estrogen, sensitive endometrial glands and stroma outside the uterus. So this is thought to happen and occur for a couple different reasons. The most common one that you all have heard of is that retrograde menstruation, where instead of the menses coming out of the vagina, it instead goes backwards out the fallopian tubes and it plants itself wherever it decides to implant itself, on the pelvic peritoneum, on your ovary, on your bladder, on your bowel. Sometimes we can even see it in the upper abdominal anatomy, on the diaphragm and things like that. There's another hypothesis that endometriosis can be part of an inherent dysfunction of the peritoneal immune system. There is also a thought that in women that have endometriosis that doesn't respond to treatment or hormonal suppression, that at the time that we are developing as fetuses, that tissue, we all develop our reproductive organs along those ridges in our pelvis. We as women have uterus, tubes, and ovaries. Others have, or men have testes, penis, and vas deferens. But we all develop those organs in the same area. And it's some schools of thought for people that are not responding to treatment that we have those endometrial tissues or those cells that are left behind turn itself into endometriosis. But it's really hard to figure out and know who those people are because everybody's endometriosis looks the same under the microscope when we're looking at it. This is a really cool picture. This is really what retrograde menstruation is really about. So I thought that represented the retrograde menstruation, and it's called the Sampson's hypothesis. And it again proposes that the retrograde flow of menstrual blood is linked to the development of endometriosis. So that menstrual debris carries sloughed off tissue from the endometrium. I keep moving my mouse like you guys can see what I'm doing, but you probably can see my mouse.
We can.
But oh, see, I'm like doing this with my mouse. So this is where this is the endometrium right here, and that's the inside lining of your uterus. This second layer of the uterus is called the myometrium. That's the muscle layer of the uterus. That's what gives the uterus its contractility. And then here are the fallopian tubes. These are the opening going out to the pelvis. And this is really what creates good, healthy fallopian tube tissue, is these fimbra, those finger-like projections at the end. So retrograde menstruation is really one that menses products is carried backwards out through. And the reason we see so many, now this picture, your ovary would normally be over here in this space and the tube wouldn't be up there. But normally why we see so many people that have endometriosis issues along the ureters and in the lower pelvis is that normally your ovary would be sitting right here and the fallopian tube would be draped over it. That's why we see so many issues with endometriosis on the bowel and things like that, because that's typically where those tubes are going to end and where the debris is going to stop. So what causes endometriosis type pain? And this might be a lot of too many big words, but it's caused by the production of substances such as growth factors and cytokines that are activated by macrophages and other cells that are associated with functioning endometriosis implants. So there are some direct and indirect effects of active bleeding from endometriosis implants that can cause the pain. Those implants, when you have your menstrual cycle, will bleed. And sometimes even during surgery, when somebody has their menstrual cycle, they may have a lot of blood in their pelvis, and we can actually see those areas bleeding, but that bleeding causes inflammation, and that inflammation is what causes the pain. Because it irritates the pelvic floor muscles by direct invasion of the pelvic nerves from these implants, especially again in that lower pelvic region in the cul-de-sac. That cul-de-sac is in the area kind of below your uterus on either side of the ovary. And this is the most, probably the one that's gathered the most support in recent decades, is why the pain is related to all of this inflammation. But remember, endometriosis itself is a disease of inflammation. So the pelvic nerve pain can be caused by damage to your nerves or nerve endings. And this damage causes your nerves to send out pain signals to your spinal cord without really needing a specific stimulus or in response to something that wouldn't usually hurt, like gentle skin stroking. And in cases of endometriosis, normal urination, bowel movement, sexual activity, and everyday activities of daily living can cause pain related to that nerve endings and that central centralization and that inflammation. So endometriosis pain is related to, I'm trying to move me out of the way here. is related to long-term exposure to those pro-inflammatory substances that can lead to peripheral sensitization, characterized by this hyperalgesic state, central sensitization that you heard me mention. That's when over time that chronic painful stimuli is what creates that central sensitization to pain, when sometimes something that wouldn't normally ever cause you pain causes pain related to that constant pressure and irritation. So we're really looking at this central sensitization as a key way to treat the long-term pain of endometriosis. And as I mentioned, it's the repetitive, persistent, noxious stimulation, and chronic inflammation and nerve injury that creates that alteration in our perception of pain processing, that again creates that pain that we feel that's constant, doesn't go away because you're constantly feeling that pressure, that inflammation. Sometimes surgical intervention may increase the sensitization and cause worsening symptoms of nerve pain, which is why sometimes surgery isn't the answer to pain, because there's often, when we have this constant noxious stimuli sensation, surgery is just creating another painful stimuli that could make pain worse. There's also some studies that have shown altered brain chemistry in women with endometriosis that is positively correlated to pain intensity, which I thought was really interesting. Move myself back over out of the way now. So how do these endometrial glands and stroma survive and grow? Evidence points to an altered immune system or autoimmune response in patients. There's decreased T cell and natural killer cell cytotoxicity. And ectopic endometriosis cells can resist destruction. So these cells that, ectopic meaning those cells that kind of stayed behind and turned themselves into endometriosis, they resist destruction, and that's why they survive. The key finding is that the ectopic, or that endometrium that's different than other endometrium in the uterus. And these lesions can express certain enzymes and produce their own estrogen, which can increase the growth and proliferation of endometriosis lesions in those people. So we all know the most common symptoms of endometriosis: painful periods, chronic pelvic pain, painful bleeding, heavy bleeding with periods, painful bowel movements, painful urination, infertility issues, irritable bowel disease, constipation, and diarrhea. I mean, they're ongoing. And all of these symptoms can be symptoms of other diseases, which I think I have on the next slide. So which is why it takes 6 to 8 years for many women to get diagnosed with endometriosis, because the symptoms mimic all of these other common disorders. Interstitial cystitis, which is painful bladder syndrome. Everybody's probably been told they have IBS or irritable bowel disease. Pelvic inflammatory disease, pelvic adhesive disease, pelvic floor disorders, chronic constipation, depression, anxiety. So all of these symptoms carry the previous symptoms. So all these diseases all act the same way, which is why it takes so long for people to get a diagnosis, and why it's so important, I think, to educate people on the realities of it. So there's many stages of endometriosis. Staging follows the American Society of Reproductive Medicine criteria. So mild to moderate disease is stage 1 to 2, moderate to severe disease is stage 3 to 4, and stage 4 disease is frozen pelvis, where everything is kind of just stuck together. Staging is really used for us as clinicians to quantify how much disease burden someone has, and to also facilitate uniformity in research and patient care. It really just lets us know how much of your pelvis is affected by endometriosis. And most importantly, staging does not equal pain presentation. So somebody could have stage 1 endometriosis with just a few little lesions, and we're going to show some pictures of what endo really looks like here in a second. But the staging, somebody could have 1 or 2 little spots and not be able to get out of bed. Somebody could have stage 4 frozen pelvis, where it's really hard to discern your pelvic anatomy, but yet not even know they have endometriosis till they happen to have a surgery for something else. So that's the most important thing. It doesn't matter your stage, you're still going to have pain, and we have to be cognizant of that. So what is endometriosis? So it can appear in different forms in the pelvis, and everybody's endometriosis doesn't look the same. And again, staging doesn't equal disease. It could look like clear little blister-like vesicles. It could look like little red erythematous lesions. They could look like dark pigmented lesions. They can look like erosions into the pelvic peritoneum, or they can even look like white scars. So everybody's endometriosis can look different, or you could have any or all of those presentations when we look during surgery. So this is my turn away if you don't want to see yucky pictures. These following slides are actual photographs of surgical patients. Some are taken from textbooks, most of them are taken from Dr. Harkin's stash of photos. But just in case somebody doesn't want to see all that kind of stuff, you guys are probably used to seeing pictures because that's what we do a lot. But I just wanted to make sure everybody knew we were going to be looking at certain pictures like that. So this is pictures of endo. This first picture here, I'm glad you guys can see my mouse moving around because I want to be able to pinpoint. So this is a picture of bladder endometriosis. So right here is the top part of the uterus, and this is bladder. So you can see how much of the endometriosis is affecting this patient's bladder. This person might have painful urination. This patient might have urinary urgency. With how invasive this looks, this patient may actually have blood in their urine potentially. This second picture is a picture of bowel endometriosis. So this right here is a colon, and this is a nodule of endometriosis that was going through the colon. You can see how it's all kind of pinched together there. There was do you think this patient was somebody that had some issues going to the bathroom and needed to have this whole area of bowel removed. This is a uterus behind the colon. Excuse me. This picture is rectovaginal endometriosis. We talked about the cul-de-sac earlier. So this is kind of the area underneath the uterus. And you can see these dark spots of endometriosis here. I like this picture here. This is the exact same picture. This picture is just normal looking during surgery. This is the same picture using what's called narrowband imaging. And it's an optical imaging technology that we use during surgery that enhances the visibility of vessels and other tissues on the mucosal surface. It works by filtering white light into specific white light wavelengths that are absorbed by hemoglobin, and then it penetrates only the surface of the tissue. And then as a result, the imaging capillaries on the mucosal surface are displayed in brown and veins are displayed in blue. And so again, this picture is the exact same one, but with that imaging, it's really hard to tell that there's really anything going on here. And somebody might say that that's normal. But because we can use that imaging, we can see this big area of endometriosis here that somebody may not be able to see. So that's really helpful sometimes that technology can help diagnosis of settled disease. Can you guys see the difference in that?
Yes.
Perfect. This is just another picture of endometriosis on the pelvic peritoneum. Again, it's red. It can look a little different there. These little white spots are just from the light. They're not anything that's abnormal. This is a picture of something that's really common that we see. This is adenomyosis. So adenomyosis is when endometriosis invades into that muscle layer of the uterus that we talked about earlier. Adenomyosis can cause extremely painful periods and cause a lot of pain. An IUD is a really good treatment for adenomyosis because the hormone is released directly into the myometrium with the IUD being inside the uterus, inside that endometrium. This is a picture of that ulceration that I was talking about. This peritoneal damage, endometriosis kind of tunnels down into the pelvic peritoneum. And this is another big reason why people that have this type of damage have nerve pain, have radiating pain, pain that radiates down their leg, people that have pain that radiates down their back is that erosive tissue. Your nerves run behind here. And so that's what causes all the pain with these types of lesions or with endometriosis in general. So this is a couple pictures now of what's atypical endometriosis. Endometriosis that can be seen, but doesn't really truly fit with the retrograde menstruation definition. This picture is a picture of an endometrioma. So an ovary, this is the white of the ovary, but that chocolate fluid. Endometriomas also can be referred to as chocolate cysts, but that old blood that's in the cyst gets to be this dark brown color. And that often is caused by some of that Mullerian transformation as well. Vulvar endometriosis is endometriosis that can occur on the vulvar tissue outside of the uterus on the skin. And then we can also see people that have pulmonary endometriosis that gets on the diaphragm. This is a picture of what's called a Viller's nodule. This is somebody that has endometriosis in their belly button. So there's a nodule of endometriosis here. This woman complained of pain at her belly button every time she had her period, and occasionally she would have some blood that would come from that area. But this is, again, something atypical, and it's really hard to explain by the retrograde menstruation that we talked about earlier. This catamenial pneumothorax, we had a patient also that had endometriosis on their diaphragm, and every time they had their menstrual cycle, they would have a pneumothorax, or their lung would collapse because of the endometriosis. And it's very commonly cyclical with the menstrual cycle. So this was my short presentation of what is endometriosis for week 1. I like this quote: endometriosis hurts everyone, but when all else seems lost, there is hope. And so I like this little yellow flower growing out of the stones, because I think it shows your perseverity and shows how everybody struggles, but that you still go on. And I'm really proud of all of you for the journeys that you've led. So thank you again for participating in this. And my references, I don't know if anybody cares about them. Let me stop my sharing real quick and double check the, I think there was something in the chat. Somebody said they're currently dealing with endo on the diaphragm. Yeah, if you have cyclic pain with your period, if you have shortness of breath, that is often another indication that you may have diaphragmatic endometriosis. You're never going to see it on imaging, so a CT scan or anything like that isn't going to show endometriosis. Most of the time, it's going to need to be seen by laparoscopy, or somebody's going to need to turn the laparoscope backwards, which is what we do during surgery to check for that, and look up at the diaphragm. So I am certainly happy to answer questions. I don't want this to be a treatment session. I can't offer clinical advice, but I can certainly share knowledge if anybody has any questions about anything that I've said, or you have questions about endometriosis.
Hey, Pam, I'll start. I have a question, because I think I've heard multiple times that I was first told endometriosis is it's an autoimmune disorder, and then I was told that it wasn't, and now I feel like you maybe just hinted that it is. So there does seem to be a connection between endo and autoimmune.
I think there can be. I think it's not directly related, but there can be an autoimmune component, meaning that we see a lot of people that have autoimmune disorders that also have endometriosis. I don't know that there is because you're not going to probably find it specifically in the literature. We see a lot of patients that have endometriosis that have lupus or have rheumatoid arthritis. And the inflammation part of it, I think, is really where that comes to where they kind of connect the autoimmune. It's the inflammation of both disorders, that when you have a flare of one, you're going to have a flare of the other. And I think it's the inflammatory response that makes that connection. Does that make sense, Princess?
Yep, it does. Thank you.
Your question in the chat says, for diaphragmatic thoracic endo cases, do we ever do VATS procedures to look at the top? We specifically do not do VATS procedures, but the patient that I referred to earlier that had the catamenial pneumothoraxes, we refer patients to thoracic surgery, and there are patients that do get VATS procedures, and that's a specific vascular cardiothoracic surgery that helps with that. How long has the light technology been around? Is this common technology for any surgical GYN, or is this mostly specialists like your office? I think that narrowband imaging has been around for a long time. I can only speak to our practice. I know when we're uncertain whether we're seeing endometriosis based on patient presentation, It's definitely a tool that we utilize in order to be able to make sure we're not missing something. So I think it's available, whether people use it or not. I can't speak to anybody else's practice but ours, and I know that we do. Anybody else have questions for me? Well, I just really want to again say thank you, thank you, thank you. I would never have been able to do it without all of you guys putting out your time and your effort to help me with these education sessions. I just really can't thank you enough for helping me do my project, and we will meet again next Monday at 7, where we will talk about treatment for endometriosis. So if nobody has any other questions or anything you want me to answer, I value your time, so I don't want to keep you. So thank you, thank you, thank you again for helping me with this project.
Pam, did you want to talk about the getting together at the conference?
Oh, yeah. Yes, thank you, thank you, thank you. I knew there was something I was forgetting. I'm not sure how many of you are planning on attending. I'm going to stop the recording here. I can figure out how to do that.